Hello, everyone. My name is Steph McMaster. I use she, her pronouns, and I'm coming to you today from the ancestral and stolen lands of the Katzie, Kwantlen, and Semiahmoo peoples. It is with gratitude that I'm able to learn, work, and live on these lands that have been cared for by Indigenous peoples for hundreds of years prior to colonization. Today, I will be providing my response to the proposition's claim that harm reduction is a requisite of healthcare. In my opening remarks, I argued that harm reduction is not a requisite of healthcare for the following reasons. First, it is a significant cost to our healthcare system. Second, it leads to ongoing substance misuse, with only 10.6% of safe injection site users accessing mental health and substance use services through these sites. Lastly, the costs negatively impact the criminal justice system and emergency health services through criminal activity and EHS responses. Once again, for the purpose of this debate, I will specifically be discussing supervised consumption sites and opioid agonist therapy, or OAT, when arguing against harm reduction being supported by the healthcare system. The affirmative's opening statement made two claims. First, that there is a need for a solution to the current opioid epidemic across North America, specifically in Canada. Second, that safe injection sites are an effective form of harm reduction because they have prevented fatal overdoses across Canada. Jacqueline also argues that opioid agonist therapy, or OAT, reduces the risk of fatal overdoses due to unregulated drug use. In response to the proposition's first claim that there is a need for a solution to the current opioid epidemic, Jacqueline cites that there were 216,000 emergency health services responses to overdoses due to the toxic drug supply between 2016 and 2024. In 2011, ECOM statistics report that there were 941,191 calls to 911. This is inclusive of fire, ambulance, and police. In 2015, ECOM statistics report that there was 1,246,520 calls to 911. Once again, fire, ambulance, and police included. This is the year prior to the opioid epidemic being declared a crisis. From 2016 to 2024, ECOM statistics reports show that there is a roughly 100,000 call number increase, and in 2023, the total number of calls was 2,342,892, nearly double the numbers of calls from 2015. Jacqueline claims that due to these statistics, there is evidence of a need for harm reduction in the form of safe injection sites and opioid agonist therapy, or OAT. However, it would appear from the numbers I have reported that what we are currently doing in British Columbia and Canada, specifically safe injection sites and opioid agonist therapy, is not working to reduce the impact on the healthcare system, specifically emergency health services and emergency departments. These statistics can all be found at ECOM 911 and are updated as of 2024. While I agree that there is a need for change in the way we manage substance misuse in Canada, it can be seen that harm reduction is not the most effective method of making that change. Jacqueline's second claim is that safe injection sites are an effective form of harm reduction because they prevent fatal overdoses. Jacqueline also cites that between 2016 and 2017, safe injection sites prevented 3,000 overdoses on site. However, in Jacqueline's first argument, she reports that since 2016, there have been 47,000 deaths due to the toxic drug supply. That means that 44,000 overdoses were not prevented by safe injection sites. The Ministry of Public Safety and Solicitor General's coroner report, published in 2018, reports that 81% of overdoses were male and 64% of people who passed away from the toxic drug supply lived and passed in their private residence. Jacqueline's claim that safe injection sites work may be true for the 3,000 fatal overdoses they prevented, but they do not address the issue that majority of people are not overdosing at safe injection sites. As seen in my opening argument, safe injection sites are actually seeing an increase in new users on average of 31 per month, but the rates of fatal overdoses continues to increase. Therefore, it can be seen that safe injection sites work, but only for an extremely low percentage of substance users. Jacqueline's last claim in her opening argument states that opioid agonist therapy, or OAT, reduces the risk of fatal overdoses secondary to the toxic, unregulated drug supply. However, Jacqueline failed to mention the increase in diversion of opioid agonist therapy like methadone, Suboxone, and hydromorphone. Redden et al., 2018, found that between 2005 and 2015, 28.7%, or 601 participants in the study, had immediate access to diverted methadone in Vancouver, British Columbia. Jones et al., 2016, found that diversion of opioid agonist therapy is associated with methadone-related fatal drug overdoses. They also found that methadone accounted for 2% of opioid prescriptions in 2009, but it was also involved in 30% of fatal overdoses. It can be seen from the statistics presented that opioid agonist therapy prescriptions are increasing within Canada in response to the opioid epidemic. However, the rate of diversion and significant risk for overdoses, fatal or otherwise, poses too great of a risk for it to be considered an effective treatment.